Good afternoon, everybody. May I please request you to put yourself on mute if you're not speaking? Hello, could you please kindly put yourself on mute when you're not speaking so that we don't have any interference with the hearing the speaker?
This meeting is being recorded.
I can still hear people. If you could please mute yourself, great.
Very bad.
Hello? Hello? Good afternoon, everybody. Hello. Thank you very much for joining in. I hope everybody can hear me very well. So good morning, good afternoon, good evening to all of you, wherever you may be from, whichever part of the world that you may be right now. I just wanted to say a good day to you. So we're going to start this webinar, and maybe just before I go ahead, may I just kindly request everybody to put themselves on mute. If you want to say anything, please make use of the chat box. It should be on the far right hand side of your computer. So if you could put yourself on mute and just cross check that you're actually on mute, and use the chat box if you want to say anything, raise any issue, comments, questions, and so on and so forth. Feel free to use the chat box. So my name is Gogontlejang, or as a nickname as you may wish, and I am the chair of the Adolescent and Youth Constituency of the Partnership for Maternal, Newborn and Child Health. I will be moderating this 1.5 hour webinar that is focusing on adolescents, the missing population in UHC, or Universal Health coverage. And I really look forward to all your interactions and engagements. We have panelists who are experts in different fields, but most importantly, because we are hoping to get key priorities, messages, and recommendations to ensure that no adolescent is being left behind in the conversations around the UHC. We really hope that you may be able to give us some recommendations, maybe also share some comments based on your experience in your line of work and so on and so forth. So that's what we will be delving into. Just to mention that this is the first webinar in this other webinars very similar to this one as we're building up to the high level meeting that is coming up. And of course, we hope with partners in advocacy plans coming up to build on the report that was released at the World Health Assembly this year that was focused on adolescents, the missing population rather in UHC. Again, I would also encourage that we take this conversation outside beyond the border, beyond the perimeters of this WebEx platform to also share on social media so others may be able to benefit from some of the key messages that will be coming from our panelists or our speakers. So you're going to be tweeting. Sorry, please remember to put yourself on mute and cross-check that you are actually on mute. So if you are going to be sharing some of the key messages or recommendations that are coming out of this webinar, please do so by ensure that you use the official tags so that we may be able to track conversation and your messages by using hashtag UHC Adolescents and hashtag UHC Adolescents and hashtag EWEC Youth. Those are the hashtags that we will be using for this webinar. And once again, please make sure that you are on mute. If you want to say anything, just make chat box and then we'll make sure that we read all of your comments that will be coming up. I will be monitoring them. I also have my colleagues from the PMNCH Secretariat carefully monitoring comments that may be coming up from all of you. Fantastic. So now I'm going to be introducing the panelists that will be joining me for this webinar, and they're going to be sharing you some really helpful insights with regards to this topic based on their area of work and their expertise. And then later on, you will have an opportunity to ask them questions, make an interventions, any recommendations to any of them. Can you please do cross check that you are on mute so that we don't have any interference? Because if you're not on, I will introduce Valentina Baltag, who works with the World Health Organization in Geneva, Switzerland. She's going to be our presenter, who's going to be giving us the overview of the Adolescent UHC universal health coverage later on. And then the second panelist, I'm going to just introduce all of them, and then afterwards, that's when I'm going to call each one of them to make their interventions. So the second panelist that I'll introduce is Cristina de Carvallho Eriksson, who's the adolescent health specialist, health section. She works with UNICEF in the headquarters that's in New York. We also have Avi Silverman, who works with Child Health Initiative. We also have Bekky Ashmore, who works in SRHR Policy and Advocacy Advisor for Plan International UK. And last but not the least, we have Souzana with YPeer. She's from Syria, and just to mention that she's also a board alternate for the PMNCH Adolescent and Youth constituency. So that is our panel of really diverse and well-vested who are going to be in the discussion today. So I'm going to start off first by calling on Valentina from WHO. She's going to be giving the overview on adolescent health and UHC, and she has a presentation. So if you could just stick to the screen, you'll be able to follow her intervention as well as the slides that she will be presenting. Valentina, you have the.
Thank you, Gigi. So in my introductory presentation, I will give an overview of some definitions and concepts. So we are all on the same page for this webinar, but also for the entire series dedicated to universal health coverage and related issues. So we will start by the definition, and WHO defines universal health coverage in the World Health Report 2010. The definition that was put is that universal health coverage is providing all people with access to needed health services, and that includes prevention, promotion, treatment, and rehabilitation of sufficient quality to be effective, and ensure that the use of these services does not expose the user to financial hardship. Now, I did highlight in this definition some key elements. You see in red all people, you see in red need health services, you see in red sufficient quality, and you see in red financial hardship. And I want to emphasize that this definition from 2010 made an important shift in the way we define universal health coverage, because before that, universal health coverage was mostly associated and talked about as financing, how much we spend. Now, this definition puts the emphasis not only on more spending for health, but also smart spending for health. What quality do we get for every dollar investment? And how smart and evidence-based our interventions are, as well as the equity dimension emphasized in the words all people. Next slide, please. In WHO, universal health coverage is our overarching framework for work. And we have recently developed our new impact framework, and you can see that we have 3 key objectives. And one is about universal health coverage, saying that 1 billion more people should benefit from universal health coverage. Now, you can also see that this goal is interlinked with 2 other goals, which are 1 billion more people enjoying better health and well-being, and 1 billion more people are better protected from health emergencies. This is because the universal health coverage and strong health systems are prerequisite to achieving those other 2 goals. Next slide, please. On the global political agenda, there is a very big opportunity coming to bring the attention of heads of states to the universal health coverage and to adolescents. On 23rd of September 2019 in New York, during the United Nations General Assembly, a high-level meeting on universal health coverage will be held. And this will be the last chance before 2023, which is the midpoint for the Sustainable Development Goals, to mobilize the highest political support for universal health coverage. Now, why I emphasize this in this webinar? Because the meeting will issue with a political declaration on universal health coverage. Next slide, please. And why is universal health coverage is a matter of heads of state? I cannot but agree with our Director General, Dr. Tedros. He said universal health coverage is ultimate political choice. It is the responsibility of every country and national governments to pursue it. Because universal health coverage is about resource allocation, and resource allocation is always a political choice. We know all too well how sometimes resources are allocated for policies and interventions which do not have evidence base to them. We also know that the opposite is true. As we build the evidence base for effective interventions, governments reprioritize how they spend scarce resources on health. Next slide, please. And these graphs just exemplify what I just said, that universal health coverage is a political choice. You can see in the graph that globally, we know that globally government spending on health increased as country income grew, except in low-income countries. And you can see the graph is exemplifying the low-income countries here is in yellow. And you can see that whereas in high-income countries, the government spending on health increased even after the economic crisis of 2008-2009, and in middle-income countries, which are here in red and green line, the average per capita has doubled, but low-income countries are lagging behind. Next slide. So to support to make adolescents visible in the universal health coverage agenda, plan led by Plan International UK and other partners and agencies, some of the representatives are speakers in the webinar, agencies, we produced a background paper which is called Adolescent Health, the Missing Population in Universal Health Coverage. And this is because with all the talk about the importance of universal health coverage, the A word was not in it. Adolescents were never sparsely mentioned in the discourse of the universal health coverage community. So we wanted to change this. And this background paper provides you with all the key arguments and key messages that might equip you in your day-to-day work to make adolescents visible in the universal health coverage agenda. We used this background paper to feature it during the World Health Assembly in May this year, and there will be follow-up. There is a coming up a call for action for adolescent health and well-being. Draft for consultations will be launched at the UN General Assembly, and there will be an advocacy push for a UN Summit on Adolescents in 2022. Next slide, please. Due to effort of the global communities, now the current draft of the political declaration, and this is the draft that will be presented in September, mention adolescent twice. And just for you to understand that the zero draft did not have the A word in it. So this is a big achievement because the document will be short and crisp, and having adolescents explicitly acknowledged in this level document gives people who are passionate about adolescents and who work with and for adolescents a mandate to demand from their government to follow up on the implementation of this political declaration. Next slide, please. So how to achieve universal health coverage for the world 1.2 billion adolescents? A short but not a simple answer is we need to move from adolescent-friendly projects to adolescent-responsive health systems. And what does it mean, adolescent-responsive health systems? Next slide, please. Basically, it means that the whole country health system should work for adolescents as well as for other population groups. We cannot afford and we cannot expect that small boutique projects based on the enthusiasm of individuals or some isolated facilities can ever contribute that every adolescent that needs the services in the country has access to those services. So we need to think systemic. What are then the health system's elements to fix? Next slide, please. Now, this is a reminder about what are the health systems in a nutshell and what are their functions. Again, I will ask for you to mute. Okay, now the sound disappeared. So the functions of the health system, the central function is the service delivery. Health systems exist because the population needs healthcare services. But in order to deliver those services, countries and governments have to ensure that there is a human resource capacity in the country, the numbers and the quality of the training of those professionals is adequate to meet population needs. Then the government and the health systems have to ensure that there are adequate medicine, supplies, and technology to support providers in delivering the package of services required. Then you have to design providers' payment mechanisms in a way that they are aligned with the priorities and with the priority package of interventions. And you also have to design financial protection mechanisms for the population. So the population, the individual and groups, when they access healthcare services, they do not experience financial hardship. And then you have to have the health information systems to help you make decisions and adjust the health system's response to the changing needs of the population. And for all of this, you need good governance and stewardship. So this is what the health system is about. Now, what are the adolescent responsive health systems? Next slide, please. The adolescent responsive health systems is when every one of those functions is adolescent responsive. It means that human resources have the core competencies in adolescent health and development. They are trained and educated in a way that they are adolescent competent. Adolescent responsive health systems also means that medicine, supplies, and technology is equally accessible to adolescents as to the other population groups. Adolescent responsive financing means that adolescent-specific vulnerabilities in financing are being taken care of. It means that the health information systems make adolescents visible, and it means that our politicians and technocrats, decision makers, they have adolescents at all time in the focus when they design policies, how to run health systems. So this is what is an adolescent responsive health system. Next slide, please. So to recap the relationship between the two, the adolescent responsive health system is the mean to achieve universal health coverage for adolescents, which is the end. You may also wonder where is primary care and primary health care in this equation. Now, because primary health care is the backbone of population responsive health systems, then adolescent responsive primary care is also a mean part of adolescent responsive health system and mean to achieve universal health coverage. Next slide, please. Now, in the remains of my presentation, I will touch upon few elements of the definition of the universal health coverage. Now, one element is what are the needed health services? The central question here is who decides what services are needed and how those decisions are made. So it is important to define an evidence-based package of health services for adolescents. Next slide, please. And the good news is that WHO now is working, and this is forthcoming this year, the new repository for universal healthcare interventions. This repository will pull information on WHO recommendations into an interactive website where users can access intervention database. So you will be able to search through the use of filters or tags for different areas. For example, you can search for HIV, and then you can search to add to your search rehabilitation, and then you can add to your search adolescents, the age group. So you will have the list of interventions currently recommended by WHO. Now, this will facilitate decision making, but this does not make it a nationally relevant package of universal health coverage interventions. Next slide, please. So from this repository, the countries will then have to come to their national packages. And to prioritize, in this slide, you can see our two resources. One is the Global Accelerated Action for the Health of Adolescents guidance, which it describes in section 4 the process of setting national priorities, and also a guidance that goes more in depth and provides practical details how you can organize a priority setting exercise in the context of adolescent health care is the AHA manual, the one with the green cover. So in both those resources, you will find how to conduct a needs assessment, how to conduct a landscape analysis, and how finally, from a list, a repository of evidence-based interventions, you can arrive at national priorities. Next slide, please. And here is the example from Sudan and Haiti. Those are two countries that recently, over the course of the last year, have used the AHA guidance to set national priorities for their national adolescent health strategies and plans. You can see, for example, in Haiti, they prioritize road traffic accidents, adolescent pregnancy, HIV, substance use, and then positive development and violence as cross-cutting issues. Next slide, please. Now, there is no country that does an excellent job for all health system elements. If you ask me, to provide example of a program of a country that has universal health coverage for adolescents implemented, done, there is no such country. But there are many examples how some countries did better on some elements of universal, on the road towards universal health coverage, because universal health coverage is a journey. It's never an end. Here is the example that you can read in full in the AHA guidance, how the Republic of Moldova started to strengthen the capacity of human resources to have adolescent competent workforce by strengthening the state medical university curricula. So now during the very short time, actually, during 2 years, and this is again emphasizing the importance of commitment to do the change. During only 2 years, they made changes in residency training of family doctors, in residency training of pediatricians, in residency training of obstetricians and gynecologists, and added a decent amount of hours dedicated to adolescent health and development. Next slide, please. Another example comes from Argentina, and this is about making adolescents visible in health management and information systems. Again, you can read this case study in full in AHA guidance. Next slide, please. A couple of examples on financial protection for adolescents. For example, in Norway and Sweden, there are user charges or co-payments for certain services. But in Sweden, for example, almost all country councils exempt children and young people, defined in Sweden as under 20 years of age, are exempt from fees for healthcare and dentistry. Next slide, please. The example from Nicaragua, and there are many examples from low and middle income countries on introducing voucher programs and schemes to increase the access to various services to adolescents and not only. Next slide, please. And here is the example from Sudan, where the increase of the proportion of adolescents that have valid health insurance cards is one of the objectives of their newly developed adolescent health comprehensive strategy. And this is an important change. In my work in WHO for almost 16 years, I have reviewed many national strategies and plans, and I have never seen an objective or an expected result related to financing. So to put in a strategy very concretely that the expected result is to ensure that 50% of services are provided free of charge to adolescents and 80% of adolescents are protected by health insurance is, in my view, a very important achievement and a very concrete result. Because very often we have good strategies with good expected goals and objectives, health-related goals, but we are not talking about the elephant in the room, which is the financial protection of adolescents. Next slide, please. And in this last slide, I make reference to the AHA guidance as a resource to read more about adolescent responsive health systems and universal health coverage. The entire section 5, the guidance is dedicated to this. Not the entire, but there are also sections about the role of other sectors, but most of this section is about adolescent responsive health systems. And also, as I mentioned in section 4 of the AHA guidance, you can see how you can arrive at national priorities, which is part of the work that needs to be done for universal health coverage for adolescents. I will stop here, and if you have some immediate questions for clarifications, and I would be happy to answer, and over to Gigi to moderate it.
Thank you very much, Valentina, for that really insightful and quite comprehensive presentation, and as well as giving some information, links on where people can read further about the adolescent and universal health. So I think there's one question, maybe you could also respond to the when you answer the question. The first question, please make sure everybody is on mute. The first question is, in the WHO health system framework, where are the action on social determinants? That is a question from Betsy, and I see another. Just she says one of the criticisms of this graph is the missing people component. For HSS communities should participate, therefore adolescent population should participate. Adolescents should have an active role, strengthening the health system, well, HSS system strengthening. So maybe you could talk about the level of engagement of adolescents in all these processes. And I think the last question is from Souzana. She's saying, do I have permission to tweet these slides? She was taking snapshots during that. So Valentina, go ahead.
Yes, thank you very much. Very good questions. Indeed, what I presented schematically as WHO Health System Framework is a simplification. So the importance of engaging communities and the users of services, in our case adolescents, is very much important and emphasized in all WHO documents related to universal health coverage. In the AHA guidance, you can see many examples of how adolescents were engaged in the process of developing national strategies and plans, or in the process of setting the voucher schemes. So many examples of adolescent participation. More recently, we documented the case study, in-depth case studies from Sudan and Barbados that underwent the process of developing comprehensive adolescent health strategies and plans based on the AHA guidance. And you can see how massive youth engagement as compared to their previous experience. I'm not saying that it was ideal, but as compared to how they used to do things, for this strategy, the youth engagement was really massive. Gigi, did I answer all questions?
Great, thank you very much for that, Valentina. And there was also a question around whether it's okay to just publicly share all the information that you've just presented from Susan.
It's fine from my side. I don't know if PMNCH you plan to share the slide deck with participants, but yeah, you can share it.
Thank you very much. Just to say that this webinar is being recorded, so after that, the recording will be shared in case if you just want to revisit the presentation from all the panelists, or maybe you also want to share the recording with your other colleagues. You could just definitely follow up with PMNCH to make sure that you get the recording. Great. So I'm getting great positive feedback from Yvette and Suzanne. So I guess Valentina, they're very happy you have satisfactorily answered their questions. So now I'm going to move on to the other panelists that we have on the webinar after Valentina has sort of just painted a really broad overview of where we are in terms of adolescent health and UHC. So now I'm going to have panelists speaking to different areas and components of this based on that expertise. And the first panelist I'm going to invite to speak is Avi Silverman, who works with the Child Health Initiative. And Avi, I just want you to share with us on what your organization is doing in terms of addressing some of the underserved, emerging adolescent health issues, and what kind of global advocacy are you driving as an organization to ensure that no adolescent is left behind? See, Avi, you have the floor.
Thank you very much, Gigi, and good afternoon to everybody. I hope you can hear me okay. Yeah, I'll just very briefly introduce the Child Health Initiative and what we're focusing on, particularly as it relates very, very heavily to adolescents and adolescent health. The Child Health Initiative, we're a partnership for the Sustainable Development Goals. We include many of the international organisations in the partnership, UNICEF, UN Environment Programme. At the core of the partnership is the philanthropy, the FIA Foundation, which plays a leading role, and also some of the key experts on some of the big development issues affecting us through the Sustainable Development Goals, particularly issues such as urbanisation and safe urban environments that are becoming increasingly important as we go into the Sustainable Development Goal period. I want to focus a little bit on some of the main trends that are facing us, and many of you may well be aware of this, but really to highlight them, that by 4.9 billion, 60% of the world's population will be living in cities, and the majority of that population, 60% of them, will be under 18 years of age. So we're facing a huge youth increase, particularly in our cities, in our developing cities across Africa and Asia in particular. This youth, and with that comes an urban challenges, but also urban opportunities. And on the challenges side, you know, we have an urban poverty challenge of somewhere around 2 billion people living in slum-like conditions. By 2030, a 50% increase on the situation today. Urban health burden, sanitation issues, the rise of non-communicable diseases, pollution, and issues such as road traffic injury, which affect adolescents, young people in particular at the front of these health burdens. But also we have an opportunity with these youth populations to deliver the Sustainable Development Goals, young people to be at the forefront of the SDGs, to deliver and to increase our economic potential, equity, combating poverty, developing our economies and employment opportunities. So with all of that, really, it's something that we have to address very, very carefully as a development community, and it's something, as I'll go on to say, that we need far more action on. And that's what we focus on at the Child Health Initiative. I'll just go on to this slide here on the burden of disease. I mean, what we see is that the global community has done well, but needs to do more, admittedly, on younger children, on under fives health. There's been a strong focus on issues such as neonatal issues, issues such as diarrheal diseases and malaria for younger children. More needs to be done on this, but there is a response in place at the very least. What we see for older children, for that kind of second decade, the 10 to 19 years age group here on this slide, is that increasingly we've got issues that aren't being addressed in a coordinated, systematic manner with adequate funding globally behind them and adequate national responses. And issues like road traffic injury, issues like self-harm, which are obviously linked as well to mental health issues, sexual reproductive health as they relate particularly to adolescents need far more concerted attention, and they are the leading burdens, health burdens for adolescents, for young people that need to be addressed. And as Valentina was raising, I want to echo her good news. The good news is, with the accelerated action for health of adolescents that WHO and partners have launched, we have the solutions to all of these terrible health burdens. We can address them. We can ensure that there is a situation where young people who should be at the prime of their life and who should be really leading social change and development in many ways, should be able to reach their potential. They should be able to survive and thrive. All of these health burdens are preventable, and we have the solutions to them, whether it be support for psychosocial help and mental therapy, whether it be the non-communicable disease best buys on alcohol and diet and physical activity, and also the systemic structural programs that need to be in place on alcohol and tobacco, and issues such as nutrition and sugar. Whether we look at road traffic injury, there's a package for the SDGs that the World Health Organization has put together. It's reflected in the accelerated action for adolescents, really focusing in on where young people are. A lot of these programs much better in terms of where young people are, linking in with the education sector around schools. On road traffic injury, for example, there are programs that are reducing road traffic injury significantly through infrastructure and policy measures around schools to create safe school environments. And the same for issues such as sexual reproductive health, where we have health services in place, but often, as Valentina was also touching upon, these health services are not adolescent friendly, are not friendly and accessible for young people, and need to be smarter in the way that we design them. So all that can be done, but is not being done systematically and globally enough at the moment. And one of the big things behind all of this is the lack of funding that I just want to focus on very briefly. There's around about $36.4 billion. This is the slide here, in development assistance for health each year. This slide here is some analysis that was put together by Professor George Patton at the Lancet Commission for Adolescent Health. He looked at 132 countries, so it's a large proportion of the whole situation, but it's not the entire worldwide. In his analysis, he looked at $23 billion, just over $23 billion of health assistance for those 132 countries, and across them, only 529 million was being targeted at adolescents. That's little over 2% of total. It's a very small amount, far too small for the health burden. If we were to look, and also on the chart on the right, you see the situation with the health burdens there. Road traffic injury is 0.3% of that, to just over 2%. Issues like interpersonal violence, which is also a huge burden as well, is 5% of that. Very small
If you could
amount.
please wrap up in 30 seconds, that would be great.
Sure, absolutely. So thank you very much, Gigi. So effectively, we need much more funding. We need to accelerate the action for adolescents. We need smarter funding and coordination. And that's all going to be included in a global call to action that partners are going to launch in New York at the UN General Assembly in September, as Valentina introduced, looking to really deliver for adolescents within universal health coverage, looking to make commitments on health globally, to hold a global summit on adolescent health, on adolescents, which really needs to be done to increase the level of funding globally for them, to do smarter funding, and to also, very importantly, engage with young people and have young people very heavily leading this and at the forefront of this entire agenda. And that's where I'll leave it for now. Thank you very much.
Thank you very much. very much, and absolutely great work that you're engaged in at Child Health Initiative to keep up the great work. We will take questions at the very end of after the last speaker. We have 3 more speakers, so if you have any questions, go to the chat box and please specify whom you are addressing the to, so that it's easy to follow up. And I can see that Valentina and Cristina have been responding to some of the questions as well. So that's great. Feel free to engage on the chat box. So now I'm going to go to the next speaker, Bekky from Plan International UK. And Bekky, I just wanted for you to share with us what Plan is doing, the work that you're engaged in to change behaviors around NCDs adolescents. You have the floor.
Thanks very much, Gigi. So Plan International, for those that don't know, is a development and humanitarian organisation that works to advance children's rights and equality for girls across the world. And today I wanted to tell you about a programme that we're currently running in 7 countries, which is the Young Health Programme. And this is a global initiative that supports and promotes the health and well-being of young people, so from the age of 10 to 24, in marginalised communities. And we do this through research, advocacy, as we've kind of talked about with the policy paper earlier, as well as on-the-ground programmes. And this is specifically focused on non-communicable diseases, or NCDs. And so at the moment, Plan is running this programme in Zambia, Brazil, India, Kenya, Indonesia, Vietnam, and Myanmar. NCDs, we focus on 5 of the main risk factors, which is tobacco use, harmful use of alcohol, physical inactivity, unhealthy diet, and air pollution. And these are the 5 main risk factors that contribute to the 5 main non-communicable diseases that affect adolescents and adults as they grow older. And that is cardiovascular diseases, type 2 diabetes, cancer, chronic respiratory diseases, and mental health. And we know that a lot of the behaviours that adults have regarding unhealthy behaviours such as smoking, alcohol use, inactivity, these really develop and cement during adolescence. So this is a really key time to be tackling these issues. So to do this, we take a really holistic approach to addressing non-communicable diseases and promoting long-term health for young people. And this is an approach which incorporates gender inequality throughout the programme, and also fundamentally includes sexual and reproductive health and rights and mental health, as you can't just work with adolescents on one issue. To get the benefits, you've got to tackle everything. So the significant crossover and influence of these areas of NCD risk factors, because these are fundamental barriers to young people leading healthy lives, and as I highlighted, you really need to focus on the underlying social factors to promote good health and well-being, particularly in disadvantaged communities. So just briefly, we do this through 4 interrelated and reinforcing ways. So one is through empowering young people. So this is building young people's knowledge and skills on what is a healthy behaviour and way of achieving good health. And this includes SRHR, gender, mental health, that allows young people to make informed choices about their health. Alongside this, we work with communities, so schools, families, community leaders, on the knowledge and awareness of non-communicable diseases, of how to prevent them, and integrating it into broader adolescent health needs. And it's really important that we work with these communities to get their buy-in and support to help adolescents lead a healthy lifestyle. And alongside all of these things, it's obviously really important that the health service is strong and able to respond, as Valentina was highlighting earlier. So this is working with health systems to make sure there's access to quality, youth-friendly services so that they can meet the needs, the very specific needs of young people. And to help this happen, you can do all of these things, but if the policy environment isn't right, then the gains that you can achieve will be limited. So we work with partners, many of them on the call today, to advocate for an enabling environment. So this is strengthening the legal and policy environment that can promote better adolescent health. So I'm going to leave that there and I'll take other questions.
Thank you.
Do you want me to briefly say about the SRHR element of the high-level meeting, or should we come to that later?
Yes, you can go and yes, go ahead and please just very briefly.
So as Valentina mentioned, the zero draft for the high-level meeting is currently being negotiated, and as well as the adolescent-specific element, which we've been able to get the magic A word in there. Just to say that there's also a couple of paragraphs specifically relating to sexual and reproductive health and rights. And as expected, these have proven to be a slightly more contentious area of the negotiations. It's an area, as within our programs, we feel that sexual and reproductive health really needs to be included as a key part of universal health coverage, particularly for adolescents to be able to access the services that they are entitled to, and we will kind of see what the zero draft comes out with. At the moment, this is the area that is still undergoing negotiation, and there should be an update from New York later this evening about what negotiated text will look like.
Great, thank you very much for that very comprehensive update, and of course, touching down the political landscape atmosphere currently on the negotiations. Bekky, that was really insightful. And just to say that towards the end, your microphone was fading a bit, so maybe you could fix that so that later on when you answer the question, it doesn't keep fading, coming back, going. But thank you very much for that. And maybe before I go to the next panelist, let me just take a comment from Twitter. And see Maxine Betau, who works with the Children's Investment Fund Foundation in Kenya. He said, my take is that to deliver UHC for adolescents, they need to improve laws, policies, and service delivery, governance, increase financing. We should not shy away from exploring and experimenting for innovative ways to meet the needs of gender and culturally responsive approach. Thank you very much for that. Please do remember to tweet using the hashtag Adolescents as well as hashtag #eWorkYouth, and those on the webinar, feel free to put your questions on the chat box. After we are done taking the interventions of all the panelists, we will certainly read your comments and they will respond. Now I'm going to our youngest panelist, and that is Souzana. She's with YPeer Foundation, and she's from Syria, and she's also a member of the Adolescent and Youth Constituency for PMNCH as a board alternate. And I just wanted to ask you, Souzana, you've worked a lot on the field and in different contexts. What are some of the best practices to make sure services respond to the needs of adolescents, including issues such as SRHR as well as gender-based violence? Souzana, you have the floor.
Hello, everyone. Thank you, Gigi, for that. I think it's very important to reflect on the good practices in the area of sexual and reproductive health and gender-based violence. We continue to learn about this field and considering the existing gaps in data, knowledge, and services. So I'm just going to share some lessons learned from the field while I was working in the civil society in Syria. Where we were working on a couple of projects, mainly to promote comprehensive sexuality education and to establish youth-friendly spaces to provide sexual and reproductive health services and protection in response to gender-based violence. One of the lessons that we learned in the hard way, actually, is to adopt a holistic approach when we addressing these issues. A holistic approach in terms of knowledge, skills, and services. Knowledge to raise awareness among young people about how to protect themselves, ways to reach services, and also in terms of skills, whether it's practical skills or interpersonal skills. And of course, the services should be available. So one example in that sense about what we've learned, so we used to give awareness sessions about how important it is to protect yourself, to have a protected sex, to use condoms, and then if young people don't have the skill to do that, the knowledge will not be enough. So there would be a gap. The same way is if we have knowledge and skills, but the surface is not there, so there's a gap as well. So that's why we thought it's very important to have a holistic approach. If we were not able to provide these services by ourselves, we were working with other organizations for referrals to network, using very interactive and peer-to-peer approach to attract young people to and adolescents to these services by also going to them and not only waiting for them to come to us. So we would approach them in schools, in their public areas. We would give them just a glance of like, what do you know about this and what do you know about that, and let them know that they can come to us for services and for information. So adopting a holistic approach is one of the lessons that we learn. The other thing is to do our research before we design our programs, to see what is relevant for this particular community, to see what is relevant for this particular group of young people or adolescents. One of the lessons or examples, when we started talking about contraceptions, we used to list a lot of like we used to list many methods of contraceptions for young people. We raised awareness about this, and then we realized that many of those methods are not usable, they are not common or not available even in Syria. So this was a bit confusing for young people. This was a mistake, and then we learned from it to do our research before going to the field, and you know, that would be better to make the services more friendlier for young people. The third thing is to advocate to gain the trust of the community. For example, just very quickly, we started working with schools, and we saw a resistance from the management of the school because of the controversial issues. So we started very soft with topics about youth empowerment, values, and then we gained the trust of the community, which is the school, and then the trust of the young people. We started to talk about more controversial issues like HIV/AIDS and STIs. So advocate to gain the trust of the community is one of the most important lessons that we learned. This is just a highlight of the lessons that we learned. I can also provide some lessons maybe afterwards. Thank you, Gigi.
Thank you very much for that, Souzana, and really just to commend the amazing work that you have been engaging in. It's really commendable how with engaging adolescents and young people in your sphere of influence. So thank you very much for that. And now we're going to go to the last panelist, and before we can open up questions and other comments from all of you, but please do keep posting your questions on the chat box so that I can just refer to them. We go to the Q&A. So now I'm going to give the floor to Cristina, who's with UNICEF headquarters in New York. And Cristina, I just want you to just tell us what are the plans? I mean, a UN agency as big as UNICEF, how are you going to make sure that adolescents prioritize at country level, and particularly in addressing issues such as mental health? So, Cristina, you have the floor.
Thank you so much, Gigi. I hope you can hear me well. So responding to your question, firstly, an organization like UNICEF needs to clearly spell out in its strategic and policy documents that adolescents are a priority target group for them. For UNICEF, this is articulated in our strategic plan and gender action plan. For UNICEF, responding to adolescent health and well-being meant a broadening approach from our previous focus on survive to also thrive, in line with the global strategy, and which all countries have committed to through the SDGs. Secondly, an organization like UNICEF needs to advocate for adolescent health and well-being with governments. But to do so, data is needed that shows the situation of adolescents in a country. UNICEF can support national or subnational situation analysis where the most pressing issue for adolescent health are identified. As I was asked to talk about mental health, I'll give you that as an example. Most mental health conditions that people experience during a lifetime appear already during adolescence, and mental health conditions affect 1 in 4 people over a lifetime and are responsible for more than 10% of the global burden of disease. Mental health conditions are also a leading cause of disability in terms of years lived with disability, and is equivalent to nearly a quarter of disability in children and youth worldwide. So this is data that we know at the global level, but very limited data is being gathered at national level. And global data is based on estimates from a small number of countries, mainly high income. So UNICEF is therefore leading the development of measurement tools for population-based surveys like MIS or demographic health surveys that countries can integrate to their surveys. So thirdly, based on this data, we can support countries to prioritize interventions to respond to the health and well-being needs of adolescents. And a role for UNICEF is also to support the development, testing, and rolling out of this evidence-based intervention that can be delivered by a national, subnational, or community systems based on available capacity. For mental health, interventions can be at various levels, from universal to targeted. And we have already discussed social determinants, and this is really important for mental health, where a secure and enabling environment to ensure a possibility for personal development without being subjected to discrimination and marginalization is key for adolescents. So that is, adolescents need to respond to these needs. And to achieve these, governments need to make investments across sectors like education, social protection, and health. And organizations like UNICEF that works across multiple sectors can have a great opportunity to support governments to convene stakeholders and develop a comprehensive and multi-sectorial adolescent health and well-being agenda with partners at the country level. So fourthly, UNICEF is taking a dual approach regarding mental health, where promotion and prevention of mental conditions is one, and together with WHO we are developing an intervention package for this, while at the same time we ensure mental health and psychosocial support care and treatment is provided through primary health care, community systems in both development and humanitarian context. And last but not least, as previously mentioned, and I want to reiterate that to ensure that services are acceptable to adolescents, they need to be part of planning, implementation, and evaluation of these services to ensure that they are provided where they can access them and in a manner that responds to their needs. This is, of course, a key part of the implementation strategy of the AHA and also for UNICEF. Thank you.
Thank you for that, Cristina. Definitely very insightful and quite understandable. And I think now we will just go to the questions on the chat box, and then maybe I'll just one speaker after the other. You'd like to respond to either. I think the questions are very broad, so any of the speakers who would like to answer them, you can signal that you want to respond. The first question I'm going to read is from Prudence, and Prudence says, is anyone addressing the needs of older children and young with disabilities? Then there's the question from Betsy that says, how adolescents while preventing a reduction of when more questions, the other question just moves back. How to make the case for adolescent while preventing reduction for other age groups or the 5 countries to ensure that right balance for communities and families, all age groups are important. The other question is, are we approaching the issue of adolescent mothers who have so little children's lives? Question from Dorothy is, can you provide more detail about how you gained trust of community in your advocacy work? I think this question goes to Souzana because she was talking about that she's in community. And there's another from Rajesh. Rajesh said, Cristina, UNICEF offices and CAA region are taking time to adolescent health programs. It leaves a gap in HC efforts. And a question from Mommy. Thank you for a great presentation. Suzanne, what is the best entry point to trust of the community, parents, and adolescent based experience? I think it's also another question that talks about how you gain credibility in your advocacy when engaging with communities. And I think also maybe in the context of where there might be a bit of resistance and what kind of approach do you use to effectively engage the advocacy effort. So let me start with Souzana because she had most of the questions, and then after Souzana we will take Avi, Cristina, then Bekky. Souzana, you have the floor to respond just very quickly.
Thank you, and thank you for people who commented. So I listed a couple of action points that we've done. First of all, it's very important to use the dialogue and the language of the community. Use a very simple language. If they are conservative, you have to talk to them in their way because you need them to accept you first. So, for example, in my work right now, we don't call our program GBV, we call it Women Empowerment because they don't accept, the community does not accept that there is a gender-based violence. You see, so you have to use the language of the community in order to gain the trust. This is one example. The other thing is to involve them in the design of the interventions. Sit down with the leaders of the community, with the women, with the children, with everyone who's involved in this intervention, and talk about the issues that they have, highlight the issues that they don't see, and then tell them how we can work together to design this program, and then they will see, they will feel more, attached to this intervention. The third thing is to work with the leaders and the influencers. Those people are the key people that we can have an entry point with the community through them, and they can influence a lot whether our programs are well done or not. So these are the ideas from the top of my head. Thank you.
Great, thank you for that, Souzana. Absolutely, really true. And the others, you can also feel free to contribute if you have anything to add on how to gain credibility when engaging with community members, the best approaches that have worked in different communities. So now I'm going to go to Avi. Do you want to respond to any of the questions or comments?
Yeah, sure. I mean, the first one I'll just very quickly respond to. I know on in the chat box on it in terms of younger child and adolescent investment. I think one of the traps that we're falling into globally is that we're looking at these two as mutually exclusive, and they should be seen as much more of a continuum. You know, if there is significant investment going in globally into under fives and into younger children, then without there being an investment in adolescents, that earlier investment is significantly at risk. We do a lot in terms of health and welfare for younger children. If then as they grow into adolescence and the health burdens are not being addressed, then we're going to be going backwards in terms of our development efforts. And also at the same time, we're not talking about competing between funding, we're talking about looking to really link in with other sources of funding, particularly as goes beyond adolescent well-being, goes beyond the health sector. And then in terms of disabilities as well, I'd just very quickly highlight we work quite closely with organisations like Humanity and Inclusion, looking to see how services, looking to see how the education sector and implementing programmes in low middle income countries to have accessible services for all, including those particularly with disabilities, and making, you know, a positive change for those for people that are often marginalised, and that needs to be a very strong focus, obviously, of the adolescent agenda.
Thank you very much for that, Avi. And maybe just a soft reminder, could you please put your microphone on mute so that you don't interrupt the audio? Because if you're not on mute, people might not be able to hear whoever is speaking. So if you could kindly put yourself on mute and just also cross-check that you are actually on mute. I'm going to take two more questions from here so that the other speakers also respond to them. It's a question from Surabi, and Surabi says, how can we ensure greater involvement of adolescents in monitoring and evaluation for adolescent health programs at local and global level, which moves beyond mechanism? Please put the microphone on mute. Just a reminder, microphone on mute. Thank you. Great, better. There's another question that says, discussed at the beginning, UHC is about financial protection. Is there any example of mechanisms to provide health insurances to emancipated adolescents and, for example, adolescent mothers? So let me take those two so that when you respond, you could also maybe touch on those. Can we go to Bekky from Plan? Do you want to take one of them?
Yes, I can do. And just to pick up on the child and adolescent conversation that we were just having, I'm not an expert in this particular area, but I believe there's quite a lot of research that shows that adolescence is an opportunity to catch up on any developmental areas that might have been missed with under fives, and the brain and development of the human body there's so much going on during adolescence that it's a really key intervention time to keep going and build on gains that happened in the early years, but also as a chance to catch up. And we quite often talk about sort of the triple benefit of investing in adolescents. So for them at the moment, for their future adult health, as we mentioned, that behaviour really sets in place during adolescence, but also for the future generations of their children and the behaviours that they will pass on to them. So hopefully that will feed into those conversations. On the adolescent mothers and the health of their children as well, I think this is where the acceptability element of universal health coverage really comes into play, and that's making sure that the services that are available to adolescent mothers are non-discriminatory. The adolescent mothers are treated with dignity and respect when they access services, and there might be specific services that they need to be reached with and specifically targeted with. That may be something very concrete, like postpartum contraceptive use. It's a really ideal time to talk and educate and provide access to services in that time. I think the key is that they've got to feel like they can approach the health system and not be rejected or shamed, so that they will keep coming back and feel comfortable in accessing it for them and their children going forward. Lastly, the not so small question of how to involve adolescents in the monitoring and evaluation in a non-tokenistic way. Just some very quick thoughts from me. It's really important to be involving adolescents from the beginning of the process, so not just at the evaluation at the end, and involve them on an ongoing basis and be providing feedback if services are changing because of the feedback from adolescents, to tell them that if it's not possible to do the changes they want, let them know, and then you can discuss and find alternatives. But it's not just bringing in adolescents at the end for a one-off opportunity. It must be an ongoing conversation. But I'm sure others have got plenty of other good ideas as well.
Great. Thank you very much for that, Bekky. And now just to move on, I'm going to take also one more question to just to the questions to respond to. And this is from Kate. And Kate said, how can we best address issues like road traffic injuries and drowning that are leading causes of adolescent mortality in many countries, and put significant pressure on the health system, but where many of the solutions needed to prevent the injuries are the responsibility of other sectors? Are there good examples of multi-sectoral and multi-stakeholder action for adolescent health, particularly related to injuries? And I'm going to give this question to Valentina, because I know that also there have been a couple of questions that Valentina has responded by referencing the AHA. So maybe you could also elaborate more on that, and maybe also share on where other stakeholders who may not be aware of where they can access our framework, they can get access to it. Valentina?
Yes, thank you, Gigi, and thank you, Kate, for the question. I actually typed the short answer in the chat. In the AHA section 3, in the main document, you have all evidence-based interventions to prevent and deal with intentional and unintentional injuries summarized at all levels, starting with the individual level interventions, going up to interpersonal, community level interventions, organizational, macro level interventions. So all what works in preventing and managing injuries is summarized there. Now, concrete examples from countries, we also have them in the AHA main document, as well as in the annexes of the AHA guidance. For example, I don't recall from which country there is in-depth description of an experience in a country when changed the law. I think it's from Southeast Asia, changing the law on reinforcing the helmet use. Then they were able to show a dramatic decrease in road traffic. But there are more examples of this kind in the AHA guidance.
Great. Thank you very much for that, Valentina. And thank you very much for all of those who have been asking questions. There are a couple of people as well. I can see Janine has been responding to questions from Dorothy. So please know that it's you're free experiences to add on to what the panelists have already said. So we're just left with less than 10 minutes to wrap up this webinar. And I wanted to just go back to the panelists, and each one of them has just a minute, and not even more than a minute. So in just 1 minute, each of the panelists, I want you to give just one key recommendation, or maybe one key message that you think for you captures what should happen in terms of adolescent, ensuring that they're not the missing population in UHC. So you can either give a message or you can give a recommendation, but just in one sentence, one line, and not more than that. So I'm going to start with Valentina, because she's the one who started first. The key message with regards to adolescent not being the missing population in UHC.
Thank you, Gigi. My key message is that we have to stop talking about adolescents as something separate from the rest of the population, and to think about their as right holders and users of health services and what health systems have to offer the same way as other population. For way too long, our discourse was that they are so very special, that they need so very special clinics and so very special approaches. They do because of their developmental stages, but health systems have an equal responsibility to deliver for adolescents as they have for other population groups. So
Thank you
adolescent
very
responsive
much.
health systems.
Great. Thank you very much, Tina. Avi, you're next. Keep it a little bit shorter.
I'll be very quick. Number one, that young people, adolescents, should be at the forefront leading the agenda. All of us as the international community need to enable them and support them to take the lead on this. And we need far greater levels of financing. The levels are far too low at the moment. We're not competing with other, but the levels of global assistance for adolescents probably need more than a 5-fold increase, and we should all get together globally, all of us, and far better, and that's why we should have a global summit on adolescents as soon as possible so that we can deliver for them and with them in the lead for the rest of the SDGs.
Thank you very much, Avi. Bekky?
Yeah, so I'll keep it short. We've touched on this slightly on the call, but I think the key message from me is not all adolescents are the same. They have multiple identities and barriers in facing accessing healthcare, and it's really important that we look beyond the health system, particularly social and gender norms and how that interacts with the health system. There's some fantastic work that's been published recently in the Lancet on this, so I would recommend, if you've not already, have a read of that.
Thank you very much. Souzana?
Yes, I just want to emphasize that the time of being an adolescent is the time where most of our lives will be determined in terms of our personality, in terms of the physical and how we take care of our body, how we receive services. So this stage is very important in someone's life, and we need to joint effort to do more and to work on the mental health, SRHR services for adolescents in terms of health, to ensure that we go through this stage as really equipped for life.
Thank you very much, Souzana. And last but not least, Cristina?
Thank you, Gigi. No, I wanted to point out, and when we talk about adolescents, we see them maybe as a young person, individual, but they are also parents, they are also children, they are almost grown-ups. So they need the responses they need are very complex, which makes the responses complicated to provide. And I think what was previously mentioned is that this multi-sectoral approach that we are talking about and integrated services, it's difficult to achieve, but the basis is, first we need to have common goals at the country level, I mean, and then actually put in place mechanisms so we can work together, because continuing to work in silos will not respond to the needs of adolescents and their children, because what they receive during adolescence will impact on the development and growth of their children as well.
Thank you very much, Cristina, for that. And thank you for really insightful conversations. I think a lot came out also from social media, but from here, a lot talking about the need to also look at legislative reforms, especially at country level, to ensure that we have policies and laws that safeguard the inclusion of adolescents' welfare and well-being. I had a lot of talk around financing, and I think it's about how to also debates around financing, whether it's about looking at domestic resource mobilization or looking at other financing mechanism. I had a lot around political commitment and galvanizing actions. A lot of you also deliberate on the importance of working with communities, but in a sustainable manner, working with communities and allowing the communities to be the ones to lead that. And last but not least, I think there was also consensus. It's important to ensure that adolescents are at the center of everything that we do. We need to ensure that we do not just only master delivering for adolescents, but how do we also work with adolescents to ensure that we are actually representative of what they want, and we are very much well aware of their needs to address them, all adolescents in their diversities, their differences. And I just wanted to remind us of a statement from Valentina's presentation, the last slide, where she wrote, "We need to move from adolescent-friendly projects to adolescent-responsive health system." I think that was really what sums up the essence of this webinar. For those who've been asking about accessing it, I just want to say that the recording will be emailed to those who registered and available on the PMNCH website. So if you registered for the webinar, you can access it through the PMNCH website to see the full recording of this webinar. Those who may wish to take part in the other webinars, said this is the first of a series of a couple of webinars. Note that the webinars will be every Thursday exactly at this time, except for the first week of September. So do make sure that you and register for the webinars and keep the conversation going. Thank you all for staying with us for an hour and a half, and thank you very much for the panelists. Have yourselves a great day.